Okay, so we're going to move on with our derm diseases. We don't have much today. We'll finish in an hour, guys. You got to get out early. So the next pattern is vesiculobullous. So what is vesiculo referring to? A vesicle. And a vesicle is just an open cavity. It's a bubble essentially, and see what's going to happen. What does the bulla refer to? Blister. So we know with this type of dermatitis, we're going to have blisters, right? Because it's bulla. We know that. The example is bullous pemphigoid. What does it mean that when you have at the end of a word OID? Resembles or like. So we're learning about bullous pemphigoid. Bullous pemphigoid is a subtype or version of bullous pemphigus. The GUS, bullous pemphigus, is the real, really bad one to have. Bullous pemphigoid is a version of it, resembles it, and it's less severe for the patient when they get it. Okay, so blistering disease, we know that because it's vesiculobullous, in which tense, fluid-filled spaces develop within erythematous inflamed skin. So very tense. So that bubble is going to look like it's going to pop. It's going to want to pop. It's going to be very tight, very shiny when you look at it. That's what the tense means, fluid-filled. Develop because of the detachment of the epidermis from the dermis. Remember those two layers. We talked about friction, like a blister. Those layers get, from blisters, it's friction, which causes the two layers to split. In this, it's an underlying inflammatory process that causes those two layers to split. So again, pemphigoid reflects the clinical similarity to pemphigus, another form of this blistering disease, but the pemphigus is a worse form of it. So again, better prognosis with the pemphigoid version than the pemphigus. So epidemiology, etiology, disorder of the elderly. So what ages are we talking about? 70, 60, 70 and up. Okay? Whenever we mention things in these classes, especially CMS classes, whenever we point something out, it's usually important because it's a way for you to, when you're studying, to compartmentalize things. So we know this is a disorder of the elderly. So if you know you had a question on a derm exam when the patient's only 20 years old, it can't be this because you know this only affects elderly. Do you need to know anything else about the etiology? No, elderly. Done. We know it's those patients. When you're learning CMS, again, when they point out these etiology, what's the important part? What's the differentiate between this versus this? It's because there's a reason for it. Just like I gave you with the aortic stenosis question with the age. Okay, not all the time is it important, but especially in these CMS classes, you're going to come down to where it could be two answers. And both answers are technically correct. But there's something in that question that was leading you towards one answer versus the other. And it's your job to figure that out. There was another question on your exam talking about DVT formation. But I said in the question, it was due to bed rest. So when you're dealing with, remember, Virchow's triad, there are three things. Which one of those is attributed to bed rest? Stasis. That was the answer. There was also another answer that was correct too, with regards to DVT formation. Hypercoagulability, I think it was. Making more clots. But that has nothing to do with immobilization. That is a separate component of the DVT. But the question was asking about the bed rest portion. So really read your questions on your exams. Test taking strategies. What are you looking for? So on these big vignettes, read the last line. It'll tell you, I want to know what the diagnosis is. It'll tell you what's the next treatment. It'll say what's the next pharmacological step. Now you read the vignette. So now you understand I'm looking for pharm, I'm looking for diagnosis, I'm looking for diagnostic testing. Read the last line first. It'll always say which of the following is due to whatever. Then go back and read the vignette and pull out what information you need. No difference between sexes. So what do I care? Why am I going to waste my time studying male or female? They're both the same. Move on. What's the important part? Immunoglobulins and complement are present. They're deposited along the epidermal dermal junction. So it's a form of autoimmune disease. Immunoglobulins and complement, again, deposit along that junction, and that causes the separation of the epidermis from the dermis. And you can see here on this picture, here's the epi, there's the dermis, and let me fill this in. All this right there is the bulla. That is the vacuole, the vesiculobullus. It's the vesicles right there. You see how you split, and then over here we're okay. But then we split the two layers, causing the bulla to form. So again, that's histology. We don't really do that much, but if you did, you would see the split of the dermis and the epidermis, causing the bulla to form. So these are what the blisters will look like. Large, tense blisters, erythematous base, so you can see how tense those are. Because of the shininess, they're ready to pop if you just touch them. So again, bulla, the little blisters that form. Most common on extremities, lower trunk. Also experience pruritus. That has some eosinophils, so the itchiness that occurs. And mucous membrane lesions will develop in a third of the patients. So mucous membranes, what are we talking about? Lips, conjunctiva, anus. Okay? So start looking at things, especially with these derm conditions. Is there mucus involvement or not? Because if the mucous membranes are involved, there are certain diseases that will fall under that category. Some never involve the mucous membranes. Start figuring these things out. Okay. Manifestations, these erythematous plaques, no blistering for a certain amount of time. It's called a pre-eruptive. It hasn't actually happened yet, but they may start getting some itchiness, some redness in that area before the actual vesicles and the bulla form. Bullous pemphigoid is a disease of the skin and mucous membranes only. Okay, skin and mucous membranes only. Some have developed skin lesions along a diagnosis of malignancy. So there's no increased incidence of bullous pemphigoid in cancer patients, but if you have bullous pemphigoid, you may have a risk of cancer later. Okay? It's like saying that not all wheezes are asthma, not all asthma is wheeze, same thing. Not all cancer patients get bullous pemphigoid, but if you have bullous pemphigoid, you may develop cancer. So that's the vesiculobullous pattern, bullous pemphigoid. Next one is called vasculitis, and the example is leukocytoclastic vasculitis is the example for this one. So clinical presentation, this is, again, inflammatory disorder. These are all inflammatories. Small blood vessels of the skin. So all of these, this palpable purpura, it's palpable. What does that mean? You can feel it as you put your fingers over it. You're going to feel all these little bumps from the skin. Now, let's look at this now. How would you classify those little dots right there? Petechiae, right? Because of the size. Now, what about this one? Purpura, still. Now, this is your ecchymosis. Really big area. It's just a matter of size. Petechiae, purpura, ecchymosis, smallest, medium, large. Okay, so this person's got all of it. So again, vasculitis, palpable purpura. Get that in your mind. Put those together. Vasculitis, palpable purpura. They usually will develop in crops, and individual lesions will persist a few days, less than a month, they usually go away. You'll see this in patients who have sepsis. They get these dots all over them. It goes away. Again, it's a vascular problem causing a dermatological response. But vasculitis, They usually go away. Any age, incidence, male and female. So obviously, ages, don't worry about studying ages. They don't care. Don't worry about incidence, male or female. Where will male or female matter? Like hypothyroidism stuff. That's where females will have more of that than males. But we'll bring it up to you and let you know when it happens. This is the important part. What happened before they developed vasculitis? Post-streptococcal, post-staphylococcal illnesses. I were seen 2 weeks ago. I treated them with whatever. They had sore throat, whatever. Drugs can also do it. Antibiotics. The main ones are penicillin derivatives. So again, someone comes in, you gave them penicillin, they come back 2 weeks later, they got this rash over their legs, a palpable purple rash. It's probably due to the penicillin. Let's stop that drug. Reassure your patient that these spots will go away over time, but stop the medication. Thiazide diuretics will do it as well, and so can NSAIDs. So these are your risk factors. This is the important part for this disease, because if I mentioned they're coming with this rash, what are some examples of what could have happened to this patient weeks prior? And one of these may be an answer. Kind of see how you put things together. What are the important parts of those diseases? Histology and pathogenesis. It's an inflammatory reaction involving the blood vessels in association with accumulation of a necrotic nuclear debris. This is your leukocytoclastic. White blood cells are in there. Lesions are raised and papular because the lesional skin is altered and expanded by an intense vasocentric infiltrate containing all these neutrophils. So you having all these neutrophils go into that area, that's why you get a little bit of a raised skin, because all those neutrophils go into the area, causing inflammation. That's why it's palpable. The erythematous, or the redness, or the itchiness quality of the vasculitis. Numerous erythrocytes that accumulate in the dermis of fully developed lesions. So that's the erythematous part, is the red blood cells get stuck in there as well. And the itchiness, just because they're stuck in an area that shouldn't be, it causes your body to itch. Clinical manifestations can develop at any site, but mainly going to be lower extremities is where you're going to see this palpable purpura. Purpuric lesions, most common, can also be vesiculopustules. Okay, so if it's a pustule, what does that mean? It's got some stuff inside it, pus, neutrophils, debris, all inside, so that they can develop as well. Often part of a systemic vasculitis. So some diseases will manifest on the skin. This is one of them, but if they have vasculitis, think they have vasculitis elsewhere in the body as well. So they may have some arthralgias, myalgias, and malaise. What are arthralgias? Joint pain, myalgias, muscle pain, malaise, fatigue, tired, just laying around. Okay, that's that pattern type. Vasculitis, palpable purpura, lower extremities, prior illness, penicillin, thiazides, NSAIDs. The next one is our spongiotic dermatitis. This is your allergic contact dermatitis. Got cheap jewelry is one of them. Eruption, it's going to be pruritic, very itchy, caused by a specific immune-mediated reaction to a substance. So obviously, our immune system is being kicked into overdrive, and we get this eruption later on. The acute phase, erythematous papules, vesicles, and bulla. So you can see on this image these vesicles that are popping up, filled with fluid. These will start weeping. Weeping means they just start oozing fluid. You'll start seeing the exudate, give you that pus, that fluid. You touch it, it's like yellowish or whatever. So those are those vesicles. Often the blisters will break down, causing the weeping and a formation of a yellowish crust. So as those wounds start to weep, it'll form a yellowish crust as that substance dries off on the skin. So that's allergic contact dermatitis. Incidence, hard to gather because most people don't seek medical attention when you have this. You go to the pharmacy, you get the cream to put on it, and then you move on. So no one really seeks medical attention, so we don't know the actual numbers, but we know it's going to go away on its own for the most part. Estimated it costs millions, basically in just creams for afterwards. Factors that determine who reacts to which substances, not known, maybe due to that HLA types, why some people will react, some people don't, and so forth. So the term spongiosis refers to the edema of the epidermis. Okay, so it's edema, it's spongy. That's why I think of it sponge. It's got water in there, filled with all little holes, and you get a sponge. Maybe slight, barely perceptible microscopically, or so massive that it shows up like a blister. Also going to have some perivascular inflammation, and the infiltrate is mainly lymphocytes. But you can have some eosinophils there. Obviously, if it's an allergic reaction, they're going to be there as well, your eosinophils. Always associate those eosinophils with allergies. Always going to be some sort of allergic response for the IgE to pop out. So you can see here, there, I'll change the color. You can see how that tissue that I highlighted looks different than the tissue around it. Why? Because it's filled with fluids, got a lot of edema in there, looking like a sponge, like it got expanded. We all filled it with fluid and water. So it turns like a sponge type of material with your epidermis. So again, type 4 hypersensitivity reaction. This is your delayed. And delayed, remember, requires T cells. So we know our T cells are going to be important here because this is a type 4 reaction. So there's an induction phase where the allergen will bind to an endogenous protein, and that causes a creation of a foreign protein. This is not normal to our body. It's an outside substance. It's a foreign substance. We have these Langerhans cells. We talked about those a little bit. What's the other protective cell that we have for our skin? Melanocytes. Melanocytes for UV radiation, and then we have our Langerhans cells for immune protection. So the Langerhans cells try to engulf the complex, degrade it, bring it to our lymph nodes so we can get rid of it and put it in our, eventually in the feces to get rid of it, but present these antigenic fragments on cell surfaces, causing the allergen complex to form. Now we have this allergen complex. T cells are going to come to the area, bind to it. T cells start to clone themselves. So the first exposure may not yield a reaction, but now, again, like we learned with all these hypersensitivity reactions, the first time you experience it, you may not have a bad reaction. But now your body is primed for it. So if you get exposed a second time, now you have a hypersensitivity reaction because now you've been sensitized to the allergen. If you ever had those allergy shots, those patch shots, to see at what strength you start getting a reaction, you're basically inducing inflammation to see how severe the inflammation occurs when you put these allergens on the skin. They do different strengths, and whenever you get a certain reaction, then we know that, okay, fine, at what strength of pollen do you get a reaction? At what strength of dust, grass, all the common allergens, they want to see how bad you react to it. So first exposure sensitizes you to it. The second time, you get the hypersensitivity reaction to it. Now we are in the elicitation phase. The antigen appears again. So the same thing happens. Langerhans cells come in, engulf this protein, the antigen, and bring it to the lymph nodes. T cells presentation also occurs at the site of contact because now they are recognized. This is the second time we've been exposed to this antigen. Inflammatory cytokines create an amplification loop, and that's clinically recognized dermatitis. This secondary process takes 24 to 48 hours to develop, which is why we call it a delayed type 4 hypersensitivity, because it takes time for these T cells to do their thing. Because it's T cell mediated. Remember, T cells, it's a slow process. It takes time. All the allergy responses, type 1 with the IgE, those are fast. That's why with the anaphylaxis it occurs very, very fast. But T cell takes a little bit of time to develop, and that's why it takes a little bit of time later on. Same thing with your PPD test for TB. You get injected, you come back 2 to 3 days later to see what the response is and how your body reacted to it. So some common causes, this is your rust dermatitis, poison ivy, poison oak, your nickel allergy, okay, cheap jewelry, back of a watch can cause that as well. Soaps and detergents. Very, very important to ask any patient that comes in with a rash. Did you change detergent or soap at home? Get used to asking that question when it comes to derm. Any changes to detergents or soap? Because you guys do laundry and you use the same detergent, and if you switch detergents, you may get a reaction to it because it's a foreign thing in the cloth. So ask those questions. Did you change anything recently? Okay. Hydrocortisone cream, right? Everything. Okay, and the next one, paniculitis. Erythema nodosum is the example for this one. This is the most common form of paniculitis, most commonly on the anterior lower extremities, and that's what we have right here. Number of lesions can vary. So this one, how do they look? Can you describe that? Look like bruises, right? They look pretty deep. These are deep because they have to go through the different layers of the skin. These bruises, actually, they're all within the subcutaneous fat of the skin. That's why you can't see the well-demarcated lines. When you have sharp borders, that's usually going to be an infection of the epidermis or the dermis because it's close enough to the skin, you can see the nice tight borders. Because these injuries, the necrosis is occurring in the subcutaneous fat, they're deeper. So those lesions show up like muted because it has to get through different layers of skin. Because of the way the light works, they look like bruises. But this is actually in the subcutaneous fat of the skin. So again, demarcation is difficult because of the depth of the depth of origin, the depth of the lesion. We're in the subcutaneous layer. We're not in the skin layer. Okay, women over men, 3-to-1. So yes, erythema nodosum. Start thinking about women getting this more than men. Etiology is an end result of inflammation. So they're going to have a pre-existing condition. Ask what happened in the last month, 2-3 weeks beforehand. Infection, here's your strep again. They got strep and then they come back a couple weeks later and they got this deep bruising in their shins. Like, what's going on here? It's from the medicine. Stop it, they'll go away. Meds, here's your sulfonamides. Okay, sulfa drugs, mainly used for UTIs. Okay, have you ever heard of Bactrim? Bactrim's got sulfa, whatever it's in it, but sulfa part of it. Hormones, including pregnancy, oral contraceptives, including estrogen, can be a pre-existing thing that will cause erythema nodosum to happen. And the last one is inflammatory bowel disease. Remember, inflammatory bowel disease is Crohn's and ulcerative colitis. Do not confuse IBD with IBS. IBS is irritable bowel syndrome. Underlying cause, your brain, causing you to have either diarrhea or constipation, but it's coming from the brain. Those are irritable bowel syndromes. Inflammatory bowel disease is an actual clinical thing. We can actually look at it and see it. So we'll get to all that when we get to GI. So here is where the problem is occurring in the fat layer. So you can see here's the dermis, here's your epidermis, but the problem is down here in this layer. That's why these bruises, they look like bruises. They look like very well demarcated edges because we're deep in the skin. Okay. Okay, inflammation of the fat under the skin, and it can be septal or lobular, meaning is it in the septum or is it in the actual lobe of the fat itself? Okay. So pathogenesis, septal divisions between fat compartments. The septa can thicken, become fibrotic. The infiltrates will consist of lymphocytes, histiocytes, and your granulocytes. The fat necrosis that starts in the septum will start to spread to the lobules in between. Okay, it can appear as foamy, lipid-laden macrophages or a little cliff within the macrophages itself. Not a big deal to know about that. Just know that it happens septally first and it spreads to the lobes of the fat. Immunologic, believed to be a delay type 4 hypersensitivity reaction for this one, may involve some immune complex deposition in that septum as well. So there seems to be a type 4 reaction for this paniculitis. So clinical manifestations, these tender, deep red, brown nodules, they are tender. So if you touch them, they're going to feel pain or tenderness when you go through that. Remember, guys, as you're getting to your CMS and your OSCEs now, they're actually real OSCEs, they're not skills exams anymore. You can't say a patient has no tenderness if you didn't ask them if anything hurts. Okay? You can't just report no tenderness if you never ask them, does this hurt? Tenderness is an elicited response from a patient. It's not an objective response or finding as you as the clinician. So always ask about tenderness. Does this hurt when I touch it? Mostly anterior shins is the most part. So again, most common site all the way down here. This is important down here. May be the presenting sign of sarcoidosis. Sarcoidosis is an infiltrative disease of the lung tissue. We'll talk about it a lot more when we get to palm next week. Not tomorrow. We'll do a big intro stuff tomorrow, but sarcoid will be coming up. We'll talk about it later on. So if you see these deep red-brown tender spots on the lower extremity, start thinking about other diseases. Sarcoid is one of them that it could be. Okay, and here's a little bit of sarcoidosis. We'll get to a little bit more in palm, but this is one of the diseases that affects palm and derm, as both. So nodular dermatitis, this is cutaneous sarcoidosis. So nodular, what are we thinking we'll be looking at here for this one? Nodules. They have nodules on this one. Okay? And you can see all these little nodules all over this is under the nares right here. This is very important. It's under the nose, and we'll talk about why that's important. So for sarcoid, you may start seeing these little nodules form under the nose. Hugely varied clinical spectrum, maybe mild asymptomatic disease, and it can even turn to later on a life-threatening lung disease. Often present on the face, and that's why I pointed out under the nose. And again, these nodular granulomas can occur in the pulmonary tree and other viscera. So you have these little nodules right under your nose. Well, what are you doing all day? Breathing in. So eventually, that's why that spreads from here. It goes into your pulmonary tree. These nodules can spread because you're always breathing them in, and they just get trapped and they go right there. So this is a link between a dermatological disease and a pulmonary disease. So this is your hilar adenopathy. Okay, those are lymph nodes. Hilar adenopathy. That's what you're seeing down here. So this image is what you're seeing there on the X-ray. Everyone got that? Okay. So that's a lot of the things with lupus. Now, lupus pernio is actually what it's called when you have those little lesions under your nose. It's called lupus pernio, usually on the face of those little lesions, what they're called. May have some eye issues. Obviously, we talked about lymph nodes going up, salivary glands may be affected, and so on and so forth. Liver, spleen enlargement. But the big ones you're going to see are the granulomas in the lungs, the lupus pernio, the lesions under the nose are the big ones that you'll see when it comes to sarcoid. So etiology often more frequently occurs in young adults, increase in African Americans in the United States. Mycobacterium species are very common with this type of disease. So they may have some history of tuberculosis. Histoplasma, viruses, genetics may play a role as well. So ask anyone in the family, does anyone in your family have sarcoid, any other lesions on their nose? So pathogenesis, these granulomas are present in the dermis. And these are the growths, little nodules that form under the nose. Non-caseating without central coagulation necrosis. Coagulation necrosis central, what kind of lesion would that present if we got central necrosis? What type of lesions? We talked about them yesterday or Monday. The type of, how would you describe them? Bullseye or target lesions. When the center becomes necrotic, remember the whole thing is going to be erythematous. Why is it erythematous? Because there's blood supply to the skin and blood can get into the area. If we get coagulation necrosis, that tissue is going to die from the center out, so the center becomes very pale compared to the rest, giving you the illusion of a target lesion. So in this case, they don't have it. What other disease have we learned about that has those target lesions? It could be turned into one of those bad ones. Erythema multiforme, EM. Those present with those target lesions. So antigenic stimuli elicit a T cell reaction going to happen. Is a T cell reaction going to be fast or slow? Slow. Antigens induce the T cells, recruiting more macrophages to the site, so more infiltration of these cells, making these lesions bigger because you're putting more stuff inside. CD4 helper cells direct the immune response, and the CD8 suppressor cells limit the extent of the response. So how big a response do you get? CD8 helps limit so you don't have that hypersensitivity reaction. CD4 helps direct the immune response to the right tissue that needs it. So some prototypical presentations. One is called Lofgren syndrome. With Lofgren syndrome, bilateral pulmonary hilar lymphadenopathy. So they're going to have those little lesions from the enlarged lymph nodes in a chest x-ray. Acute erythema nodosum. What's that? Those are the brown, red, bruise-like things you'll see on the anterior shin, erythema nodosum. Fever, arthralgia, uveitis. The key things are the first two. Because fever, arthralgias, and a little bit of uveitis as well, but those are pretty generic symptoms. It could be anything, but what's going to be happening is on an x-ray, you're going to see that, and you're going to see that erythema nodosum on the shins. Yes? Yep. Mm-hmm. Lupus pernio. This is your nasal rim sarcoid. Okay, these are the bead-like papules on the rims of the nares under the nose. Lupus pernio. When you have that, indicates significant tracheobronchial tree or lung parenchyma involvement. So if you see this on the nose, underneath the nose, assume those are also in the bronchial tree as well. Yes?
Does it start on the nose or it goes to the lungs first? Or?
I'm not actually sure where it starts, but obviously it goes back and forth and it just keeps making it worse.
If you have this, you have it.
Yes. Yes?
Is it, because I think it said nodular before, so is it papular and nodular?
Yeah, it is nodular. I mean, they are going to be firm. Remember, a nodule is just a firm, vesicle or whatever you want to call it. It's a firm nodule. It's the same thing. It's just one's firm, one's loose, got liquid inside. Often a diagnosis of exclusion. What does that mean? We ruled out everything else. We can't find it, so it's a diagnosis of exclusion. We excluded everything else, so it probably is going to be lupus pernio, sarcoid, erythema nodosum, and so forth. So you get a chest X-ray, bone radiographs. They're going to show sarcoid on chest X-ray. Obviously, you'll see that bilateral hilar lymphadenopathy on either side of the heart. And you go through all these things when you start medical imaging in a week or two. Okay, the last one is folliculitis and perifolliculitis, which is just acne. This is the last one. Okay, commonly presents as follicle-based comedomes, inflammatory papules, or pustules on the face, neck, chest, or back. Teenagers are stereotypically affected, but neonatal and adult acne also occur. And it can cause disfiguring nodulocystic acne. If you have the nodulocyst type of acne form, they can cause scarring, permanent scarring, and usually does not occur before puberty. So the nodulocystic acne does not usually occur before puberty, it's later on. So this is acne vulgaris. Numerous inflamed pustules and papules, central black plugs. Some of them have it, just the blackheads just means there's dirt in there. Doesn't mean you're dirty, it just means you have blackheads. Okay? So that's the one of them. So comedomal acne is manifested as a widened follicle. So the follicle gets wide, then all these keratin plug gets stuck. So this, remember we talked about yesterday, I had you all breathe in real deep and all the dead cells? Those dead cells can go into the follicle and they cause a plug. So all the oil that's continuously being produced has nowhere to go because it's been plugged up by the keratin. Okay, so an open comedome, follicle orifice is open. These are more, a little bit like whiteheads, which is just white blood cells. A closed comedome is orifice is normal and the follicle is plugged below the skin surface. Secondary inflammatory changes occur commonly within plugged follicular units. What do you think causes the secondary inflammation from plugged follicular units? Popping them. Popping them causes secondary inflammation to the surrounding tissue. We'll go over that in a little bit. That's why you shouldn't pop them, because it causes injury to this tissue around it, not the actual issue itself. If neutrophils are in that plug, then it becomes pus-filled and pustular lesion. Inflammatory acne lesions are due to follicles that have ruptured with spillage of all that debris into the perifollicular dermis, dense inflammatory reaction. Okay, and then you get neutrophils, lymphocytes, all that normal inflammatory reaction stuff that's going to be there to help fix the problem. Okay. So there are 4 components to develop acne lesions. 1, you need that unit to be plugged by keratin. So the folliculosebaceous unit, the hair and the oil sweat gland, they have to get plugged up somehow. And it's usually keratin, the sloughing skin cells get stuck inside there. Second, you need to have sebum production, which is the oil. That has to keep going. The next thing is this overgrowth of Cutibacterium acnes, which is the actual bacteria that causes acne. It used to be called Propionibacterium, but they changed to Cutibacterium. I don't know why, but it's called Cutibacterium now. C. acnes. And you need a secondary inflammatory process as well. Again, being dirty does not cause acne, and vigorous and frequent cleansing does not improve the condition either. So all those creams, all those other things, sometimes they don't do anything. So these keratinocytes become sticky and they fail to slough off because they're now sticky, and that causes the follicular plugging to happen. So now this chart is very important because it's going under the pathophysiology of why you get these different things with acne. So we have plugged that follicle. So now we get increased sebum within the follicle. All that oil acts like a food source for the bacterium. And that causes bacterial overgrowth because now we have all this, the sebum there. It's a great food source. When you have food, now you can start multiplying. The sebum degrades to lipids and free fatty acids, and that causes the expansion of that follicular canal. It gets wider and bigger. Now you get those pores showing up on your skin. If you ever see big pores, it's because these glands are wide open. The C. acnes recruits neutrophils. It's a bacteria. We need neutrophils to fight off the bacteria, but all this dead white blood cells causes pus to form, and you get a pustule form. All these enzymes from the neutrophils weaken the follicle wall, and that can cause rupture of that wall. And when that happens, large amounts of these inflammatory reactants all get dumped into the dermis, causing that other reaction to occur, causing more lymphocytes and neutrophils to respond. And now this comedome has either transformed into an inflamed papule, a pustule, or a nodule of acne. Those are the three things that can happen. Follicular rupture and intense, that secondary reaction, is what causes the scarring to occur. So here's that example. Here's our sebaceous gland right there. Here's our plugged follicle, because all this keratin is falling down into that little space and it's plugging it up. So now we're plugged up, but this gland is still pumping oil, sebum, into the follicle. It doesn't know that it's plugged. It's just the job of the gland. So we get accumulating more sebum and more keratin in that area. Now the C. acnes shows up and it starts getting food supply, it starts eating a lot. We get all this inflammation occurring around the follicle. And then finally we have this marked inflammation. Now that wall rupture, we talk about how the neutrophils make the wall of the follicle very, very fragile. It breaks. All of these pro-inflammatory cytokines and other things are all released into the surrounding tissue, causing inflammation there. So when you pop your zit, you're breaking this wall artificially, making all these reactants, all these things spread to the surrounding tissue, and it makes the acne worse. Okay, so that's kind of what goes on with acne. Obviously, this is a nodular cyst, so it's raised off of the skin level. You'll feel that as well. Clinical manifestations. Neonatal acne is a real thing. It can happen when babies are born. They can come out with acne on it. What happens and why? It's due to maternal androgens from the mother. Stimulate enlargement of the sebaceous glands, so we get a lot of growth of the sebum. Obviously, because we have sebum, C. acnes is going to show up and eat it all up. Acne will continue until the maternal androgens are cleared and the sebaceous glands atrophy to normal neonatal size. So if there is neonatal acne, maternal androgens is what caused it. Once the maternal androgens get out of the system of the baby, the acne will go away. Puberty. Androgens again. Because when you're a baby and you're growing up until you hit puberty, you don't need androgens. But now you hit puberty, androgens start skyrocketing, your testosterone, all that stuff, estrogen, starts skyrocketing, hormones go up, so sebum production also starts to rise from that, from the androgens of your own body now, and mainly happens in the face, neck, chest, and back. Onset may be gradual or rapid. The severity can range from either just primarily comedones, just simple isolated comedones, inflammatory papules and pustules, so now you have the dead white blood cells, neutrophils inside it, causing the pus to form, highly inflammatory, painful nodules, and then obviously scarring is the worst form that can happen from acne. And here's some more severe cases of acne on the chest here, and then I don't know where that is, but you can see all those open, comedones, blackheads, they're all in there. If you like watching that Dr. Pimple Popper, this is the one side of medicine I hated. I don't deal with this stuff well. And when I was on my derm rotation, that was in internal medicine, when I was a student, my proctor or preceptor was like, someone came in with a sebaceous cyst on their scalp. So like, we'll just do it in the office, we'll just pop it. And then she squeezed it and like half of it like squirted across the room. I was like, I'm done, no more derm for me. So again, this is obviously severe acne form of that. Acne can also present as a manifestation of an underlying disease. One of the main ones is a Stein-Liebenthal syndrome, also known as PCOS. So polycystic ovarian syndrome, they will have acne as well. Main reason is hormonal influences. They're going to have a lot of high androgens. Women who have PCOS, what other side effect do they also have with it usually? Facial hair. What causes facial hair to grow? Androgens. So they have high androgens because of the PCOS, more hair growth, and acne growth, because you know that androgens play a big role with acne formation. This last one is called Sappho syndrome, synovitis, acne, palmoplantar pustulosis, hyperostosis, and osteitis. I'm not going to go much detail with that. You'll probably get it in our class. Sappho and PCOS are two underlying causes that can present with acne, but the acne is caused by the underlying condition, not acne by itself. So here's some classifications. Mild acne, usually less than 10 pustules, no nodules. Moderate acne, 10 to 40 pustules, 10 to 40 comedones, and some several nodules. And then when you have severe acne, then you start getting a lot of nodules. So the worse acne gets, the more nodules you will have. That's the key thing with those ones. How many nodules are there? The more nodules, the more severe the acne is. And that's true, right? It's all gone now. So this is it for derm. It's just those 9 diseases. Know the classification of all the lesions. I put a little cheat sheet in your canvas for you with that. Otherwise, you guys are done, and tomorrow we'll start POM.
Thank you.